Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Bird, a pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. Here, we're empowering women to master midlife on their terms, reclaiming our health, our happiness, and our power. Together, we'll rewrite the narrative around this remarkable stage of life, from something to dread into a beautiful, bold transition. I'm so glad you're here. So I am so excited to welcome back to the podcast Nurse Practitioner Vanessa Weiland. She came on and joined me for a conversation we did some myth busting. We talked about hypnotherapy for treatment of hot flashes and menopause symptoms. And so when I was thinking of discussing the topic of vaginal estrogen for a sexual wellness series, I thought, what expert can I have on that will talk about it, who digs into research, who loves like the science and nerds out on this stuff just like me? And I thought, Vanessa. So thank you for coming back.
Well, genitourinary syndrome of menopause, it's like, you could call it niche, but I could talk about it all day. So I'm so excited. And how niche can it really be when half of the population goes through menopause and 80% of those experience it? So yes, very excited to get into it and bust more myths.
Yes. Well, and I think maybe it's the side of Instagram that I'm on, but I feel like it's a conversation that is more prevalent than it was even a year or two ago. And the new guidelines coming out from the American Urological Association?
Mm-hmm.
Yeah. Okay. That was really helpful. And I just wish, we'll probably already get an explicit because we use the word genitourinary and we're going to talk about vaginal estrogen, and we'll probably be shadow banned on social media because we'll say words like vulva and libido and whatever. So we're already going to get all that out of the way. I probably just completely shadow banned us in the introduction.
We'll see what the 4 people who get to listen to this think.
Well, there'll be more listeners and more email subscribers, but social media does not like when I post things about vulvas. And I've noticed that about other accounts too. When I've talked to other specialists, they're just not getting the social media traction that they should for the conversations that need to be had because it's talking about female parts.
Yeah, I made a Threads post about clitoral atrophy. And I did the whole thing where you like slightly change the punctuation, like use the @ symbol instead of the A to help it get reach. And then surprisingly, a lot of people found it very interesting. And then there was this side debate about like, well, if you're a professional, you should be using the real words. I'm like, I did use the real words. Very slightly edited them so you would see this.
I know.
That has nothing to do with me.
Yeah, I have absolutely no problem saying the words. I can talk about it and I can type it up, but that means you won't see it. So
yes,
it's so frustrating. Frustrating. Maybe someday talking about female sexual wellness won't be considered pornographic on the internet.
Yeah, I have this weird thing going on with my Instagram right now. If you try to access it from, if you're not on Instagram, if you're on your browser, it says only for 13 plus. I'm like, okay, granted, this is a menopause account.
Wow.
It's not for children, but that makes it sound like pornography. It's so annoying. So weird.
You reached a new level, Vanessa. I'm impressed. I haven't quite gotten there yet. I guess give me this series. So this is probably coming out in like October-ish. So by the end of the year,
I'll check in again.
I'm excited. So let's start off by talking about GSM and what it is exactly so that women who have maybe heard about it or don't know a lot about it can kind of really understand it.
Yeah, so GSM is the newer term for genitourinary syndrome of menopause. Already some debate around that term because it also happens in perimenopause. It also happens postpartum. It can even happen with birth control pills or testosterone for gender-affirming care. But in any case, we're talking about changes in the genital health, the urinary tissues related to hormone changes. The previous term was vaginal atrophy or vulvovaginal atrophy. And then way back when, actually was in the medical guidelines and things as geriatric. What was it? don't know. I forgot the name. Geriatric. Okay, so
now I'm going to look it up because I want to know. We'll cut this out, but that's interesting. Well, and let's see. Is it geriatric vagina?
Yeah, it was geriatric vagina back in like the 50s. So we've come a long way from there.
You know, and the thing is, I remember reading something about how they had to change to a more sensitive and more comforting term for erectile dysfunction because men were getting their panties in a twist about feeling like the words being used were harmful to their psyche. But then we have things like, vaginal atrophy. Yeah,
I think we're fortunately moving away from that as well. But yeah, I think I mean, first of all, the new name genitourinary syndrome is great because it includes that urinary piece, because a lot of people don't actually realize that the vaginal dryness they're experiencing in menopause can also affect their urinary health.
Yeah. So physiologically, what is it that's leading the body to have this GSM syndrome, the symptoms occur?
Yeah. So during perimenopause and after menopause, your estrogen levels are declining and the vaginal tissues really love estrogen and feed off of it. And so if you were to look at the vaginal walls under a microscope, there's all these like deep crypts. And so the tissue is very deep, and down in the crypts are where the healthy bacteria really thrive. So as you have less estrogen, that tissue is thinning out. And then because of that, you're losing a lot of the healthy bacteria. And then because of that, you're losing some of the acidity that keeps the environment healthy. So then that can lead to infections, urinary tract infections, vaginal dryness, difficulty with arousal, lubrication. And then you're also thinning out all the tissues. I tell my patients that if you were to look, the wall between the vagina and urethra is actually quite thin, and it's getting even thinner. So you're losing some of the support structures around your bladder and urethra as well. So that can cause things like urinary frequency, urgency, more incontinence. And I mentioned recurrent UTIs. So there's a whole beautiful package that comes together when you no longer have the estrogen on board.
Yeah. And while pelvic floor health is important and pelvic floor therapy is a godsend, it's not the only, it's doing Kegels isn't going to fix the loss of estrogen.
Right. The Kegels aren't going to affect the underlying tissues in the same way. There's a little bit of interest in maybe like a laser therapy or something like that. I don't understand the use of it. It's not going to be covered by insurance, very pricey out-of-pocket cost, and pales in comparison to the data we have for vaginal estrogen, which is very affordable, very effective.
So for those people who are interested in learning about vaginal estrogen, what are the products that we have that are available for the vaginal estrogen routes?
Yeah. So the main ones are a cream, a tablet, a ring. So I most often prescribe the cream just because it tends to be the cheapest, but it's also a little bit messier. In some ways, that's kind of nice, though. You can use it both internally and externally. The cream comes with this toothpaste tube-sized tube of cream, and it's a really like thick, sticky cream. And then it also comes with this tampon, this thing that looks like a tampon. What's it called? The applicator. So what you're meant to do is draw up the cream into the applicator and then plunge it in like you would a tampon. But my patients hate that because it kind of like goes in as a glob and falls back out as a glob. And they're like, what the hell? There's just this cream in my underwear. So what I recommend is maybe use the applicator once or twice to get a sense what the dosage is. Usually it's going to be 1 gram, or you can just eyeball it. It's usually about from the fingertip to the first joint. So put it onto a clean finger and then massage it in. And especially if they're having urinary complaints, I'll tell them favor the front, because that's where you're really improving the tissue between the vagina and urethra, like I was talking about. And then whatever's still on the fingers, you can go ahead and use externally, because that can help with the health of the tissue around the urethra on the outside, the vulva, the clitoris, all that good stuff. So that's usually my go-to. Some people don't like it. So we might do a tiny little tablet that you just push in there and it dissolves easily. Or lastly, there's a ring, and there's 2 versions of the ring. One of them is just a local option like these others. That's super duper low dose of the estrogen. Or there's actually one that gives your whole body estrogen, but it's used there in the vagina. So of course, it's also helping with the urinary complaints and vaginal complaints.
So if you are somebody who has been using hormone therapy and you're on an estradiol patch and you're on oral progesterone, is vaginal estrogen still something that patients might need?
Yeah, I would say it's about 50-50 that someone is not finding their genitourinary syndrome complaints are fully resolved with a full body patch because it's not necessarily getting to those tissues as effectively. And not only that, but there's some really interesting data around some urinary complaints actually getting worse with the estrogen patch. I don't know if you've heard that, and particularly stress incontinence. And we don't really know why. My best guess is especially post-menopause, maybe it's making the uterus a little heavier.
Okay.
But in any case, if someone has urinary complaints and it's not getting better with the patch, which I wouldn't necessarily expect it to, then I might add on the cream or a tablet, even if they're not really noticing vaginal dryness. So yeah, I'm very commonly using the two together, and that's perfectly safe to do.
And speaking of safety, there's been talks about the FDA and the black box warning on specifically vaginal estrogen being taken off because the safety data is a lot better than we've been led to believe. So do you want to talk about that a little bit?
Yeah, so I'm sure your audience knows well that a study came out in 2002 that really decreased hormone therapy use because there were concerns around estrogen and blood clot risk and breast cancer risk and heart disease risk and dementia risk. And, we can go into the details on that some other day of how a lot of that has been picked apart. But regardless, a box warning went on all estrogen products saying, if you take this, it might cause heart attack and dementia and blood clot and breast cancer. But the thing is, the vaginal estrogen is what, 1/100th of the dose of the estrogen
Yeah.
patch or tablet. So it's not getting in your bloodstream the same way. And there's just zero evidence that it causes any of those things that I just talked about. And we have, going back many years now, guidelines saying that it's safe to use vaginal estrogen if you have a history of blood clot. It's safe to use vaginal estrogen if you have a history of breast cancer. And more and more guidelines are backing that up. So not only is it safe, it's really inappropriate that box warning is on the packaging. I mean, there's debate about it even with a systemic estrogen patch, much less this vaginal estrogen, where there's literally no data to back it up. It's just factually
it's a blanket. It's a blanket scare tactic to keep us from estrogen.
Yeah.
Let's just
Yeah, and then you have someone that's, maybe they're not using whole body hormones. They just have heard that vaginal estrogen might help sex be more comfortable or might help with their recurrent UTIs. And then they get that thing, the information packet, and they're like, oh, never mind, it's not worth it for that. And it's not based on facts.
No, and that's really frustrating. And I think there's a lot of, I've talked with a lot of women who say they see everything about hormones on social media because there's a big buzz now about hormone therapy and how important it is and how it treats all these things. But then there are women who it is contraindicated for, or they've had experiences that the hormones that they tried, they just didn't feel good on them and they didn't want to do it again. And so, but mostly the people who it's contraindicated in, they feel very frustrated that they are having this issue where, they have these symptoms and they don't have anything to relieve the symptoms. So the fact that they could remove that black box warning and remind clinicians who are prescribing that it is in fact actually something that is safe and efficacious, specifically for GSM, I hope we get to that point so that these women have an answer. And we could treat hot flashes with other non-hormone therapy treatments, but the GSM, the best, like the magic bullet is really estrogen.
Yeah. There was a FDA panel on this recently, and it's available on YouTube if anyone wants to watch it. But Rachel Rubin made a really great point that the estrogen is actually in the Beers criteria now, which is basically a list of medications that are like no-nos for anybody over the age of 65, and Medicare will ding you if you prescribe it. When vaginal estrogen is very safe in that older age group, it can help prevent urosepsis, which when I worked in a nursing home was a big reason we were sending people out to the emergency room or getting hospitalized. That's one of my biggest regrets, how little I utilized vaginal estrogen back then. So yeah, I think we all agree that not only is that packet of information incorrect, it's really scaring people and it's doing harm.
Yeah, for sure. So how long does it take usually your typical patients to start seeing relief when they've been put on vaginal estrogen?
It seems pretty quick. The standard dosing would be you give it every single day for 2 weeks, and then you can go down to just twice a week outside of the ring, which stays in all the time. And yeah, usually I check in with people again a month later, and a lot of times they're already feeling a lot better by then. Sometimes if symptoms are mild, I just start them on the twice a week because it's a lot easier to manage. And they still seem to do pretty well as far as responding quickly. So yeah, it's a pretty quick turnaround.
And it's not just women in menopause. You don't have to be in full-blown menopause to have these symptoms and be able to feel this relief, right?
Yeah, you might have someone that's in perimenopause, or like I mentioned, someone who is breastfeeding will tend to have lower estrogen and progesterone as well. So you can safely do vaginal estrogen in that case. If you have a trans man who's having genital changes, you can safely do vaginal estrogen or genital estrogen there. So yeah, like I said, there's a little bit of debate around using the term genitourinary syndrome of menopause, because then it's a little bit limiting. When you have a birth control pill on board, it has synthetic hormones that are so high, it's actually dropping your own body's production of hormones. And a lot of those folks will notice urinary genital changes as well. So yeah, a lot of applications for it outside of just postmenopause.
Let's take a quick pause to talk about something I know you'll love. If you've been listening to this series, you know that sexual wellness is such an important but often overlooked part of midlife. That's why I put together a free sexual wellness guide just for you. Inside, you will find answers to the top questions to ask your provider, reflection prompts to help you better understand your own needs, insights pulled from the amazing experts and podcast guests you're hearing right here, and I've also included a page with my favorite and vetted products. It's a resource designed to help you feel informed, empowered, and confident about your sexual health in this season of life. You can grab your free guide right now at womenmasteringmidlife.com/free-guides. That's womenmasteringmidlife.com/free-guides. You'll also find the link in the show notes below. Download it today and take the next step in reclaiming your sexual wellness. How does the vaginal estrogen help with your sexual experience with your partner?
I mean, the most obvious place is if you notice that when you try to have intercourse and with penetration, it's just really dry. That it's going to help with that a lot. But some of the things that people don't realize is that as you have less estrogen, you're actually getting less blood flow to that area, and that can affect things like sensation, arousal, ability to climax. And so estrogen can be really helpful there. And I think we'll talk a little bit about vaginal DHEA, which is another favorite of mine. So it's more than just the dryness piece. Obviously, we want to fix that, but it can also improve the whole experience overall.
Yeah, I think blood flow is something that women forget is very important for sexual experience and overall health of the area. I think, you go to the pharmacy and there's shelves and shelves of colorful lubes and flavored lubes and things it's amazing to me, the chemicals that some people will put in a package to use as a lubricant, and forgetting that you're not dealing with the physiology of the loss of estrogen with those. I mean, they are important to use in occasion, but if you're not treating the underlying problem, you're going to still see issues that you wouldn't be seeing.
Yeah, I mean, I had nothing against lubricant. I think some brands are better than others, and
yes.
Even if someone's 20 and they feel like they could use a little bit more help with comfort with penetration, you can use lubricant as well. But yeah, obviously, it's not addressing the root cause if you're postmenopause and this is a dramatic change for you.
Yes, I think the issue that I was thinking of that I just didn't put words to is when prescribers don't want to go with estrogen and they say, here's a suppository of a lubricant or a hyaluronic acid. Those are helpful, but that's not really going to fix the problem.
Yeah, and I have some patients that are using hyaluronic acid as well when their symptoms are a little bit more severe. And I would say that's the product that has the best evidence outside of vaginal estrogen. But the people that are being told you need to do this as a first line, that is a diminishingly small group of people. For the vast majority of us, vaginal estrogen can be a first line.
Yeah. And you mentioned DHEA. So let's get into that a little bit and tell me what DHEA is. And because you could buy a capsule of it at your nutritional supplement store, but you're talking about vaginal DHEA.
Yeah. So there's a product that's on the market called Intrarosa. We don't have a generic for it right now, but it's a vaginal suppository. Rather than doing twice a week, it's every day. And so the hormone in it is DHEA, which is actually higher up the cascade. So it basically can convert both to estrogen and androgens. And so why would you particularly want that over vaginal estrogen is that you have to get like extra nerdy. But basically when you're a fetus, your genitals could go either direction. And then if while you're in the uterus, you're exposed to androgens, you're going to develop a penis and scrotum. But the default is the female genitals. And so those tissues are extremely sensitive to androgens. And so when somebody's main complaint is really more the like arousal, sensation, their orgasms are more muted, I'm thinking about if androgens might be more helpful on board. And I wish I had the head-to-head study of estrogen versus DHEA to say for sure one is better than the other. It's just kind of a sense that I have from working with people. The unfortunate thing is that where vaginal estrogen, we have tons of generics. It's usually very affordable. If for some reason your insurance doesn't want to cover it, you can get it from Cost Plus for $13 a tube as of now. But the Intrarosa, we do not have that option. So it just tends to be pricier.
Okay. And then it becomes a formulary issue for pharmacists. I'm thinking like retail pharmacy brain, how that always works. And that's interesting. And that is something that I'd love to see more research on, the DHEA versus the estrogen. So for women, most women that I've come in contact with and that have reached out to me don't have a menopause clinic handy, or they don't have access to a menopause specialist, or they want to stay with their provider because of insurance and care or whatnot. And they might be, and I feel like if you're not going to a menopause specialist, we still don't have the list of conversation questions in the pre-visit checklist that I think midlife women should have. And a lot of it is around your, signs of GSM and discomfort in sexual intercourse and relationships with other people or yourself. And so how do you, for our listeners out there who want to talk about it with their provider and they just don't know where to start, what would you suggest for them?
That's tricky because, my first 10, 12 years as a nurse practitioner, I was rarely bringing up sexual health. Obviously, I wasn't like scared of it if someone talked to me about it, but I wasn't the one initiating the conversation, and therefore it rarely came up. And now in my menopause clinic, I use something called the menopause rating scale, which is a validated measurement used in research, maybe to test if a product works. And that includes questions on vaginal dryness, urinary complaints. And so it comes up every time. Because of that, I say it in such a rote and routine way that I'm clearly not having any special feelings about it. And therefore, a lot more comes up. And so it has really wowed me. You just need to like tip off that conversation and the floodgates open. And it's been so fun where that might not have been even on someone's radar of this is something you could help with, the power of someone's orgasm or their arousal or the pain with penetration. So yeah, that's been a really rewarding part of my practice. But assuming that your provider is going to be like me 5 years ago and not bring it up.
Yeah.
I think for a lot of these things, I know you've heard the advice before and it's really annoying, but if you can make a separate appointment to talk about it, they can't squirm out of it nearly so easily. And yeah, I get it. These are embarrassing topics, talking about urinary incontinence or even bowel incontinence or pain with sex. It's crossing a lot of the taboos, but any healthcare provider worth their salt you're not going to see any reaction in their eyes. It's just like, all right, this is another topic for the day. And hopefully they'll handle it really responsibly. And hopefully they know that vaginal estrogen is safe. That's no guarantee. You can, of course, bring a guideline with you if you're concerned about that, because we have a slew of them now that show that it's safe in a lot of different conditions.
Yeah. And I think now, is the questionnaire that you're talking about the one that's available through the Menopause Society website?
The guidelines?
The questions that you asked, because I feel like there was
the menopause rating scale.
Yeah.
It is freely available through Science Direct because some study used it.
Okay. I will add that to the show notes so that people can look at it if they want to look at the menopause rating scale, because if they don't have, if they don't have access to it through their provider, then they can at least fill it out themselves and see if it's something that, and take it in. Like, oh, I was at home and I printed this off and I did this for you. So it's already ready and we can just talk about it.
No, you're going to seriously annoy them, but it has things like anxiety and joint pain, and they can't say, oh, that couldn't possibly be perimenopause. It's like, are you sure? Because this is a valid measurement that disagrees with you. So yeah, I think it's a great tool.
Yeah. And I hope at some point we get to having it be a standard annual, like part of the annual exam for women over the age of, I don't even know, 35. Because I think we should probably start talking about these things earlier than later. And, when there's frequent UTIs, that's another thing that I was thinking about, because I was just talking to somebody and I was saying, oh, I'm going to be doing an episode with Vanessa about vaginal estrogen. And she said to me, oh, that might be something I need to talk about with my doctor because I keep getting these UTIs. And it's like, well, you're like 46 and yeah, probably that could probably be a reason. And so I think even just opening up the conversation line with this and being able to say that it's more than just sex hurts or I have vaginal dryness.
Right. I mean, if you're having recurrent UTIs, that even if you do a trial and it turns out that wasn't the cause, it's so safe and so much safer than recurrent antibiotic use. I mean, that can have impacts for you down the line, even for your family. So yes, very strongly in the camp of trying vaginal estrogen for that.
Well, and like let's be on Bactrim or Macrobid. Like that doesn't sound like a great idea. It's hard to believe that is the answer for people when something as simple as vaginal estrogen could do the trick. So what are some myths and misconceptions you wish more women understood about vaginal estrogen?
I think we've tackled a lot of them, but I've seen a lot of things like, well, I can't use any form of estrogen because I've had a blood clot or had breast cancer. And the guidelines that I like to share regarding those two things both come from ACOG, American College of Obstetricians and Gynecologists. If you just Google ACOG, estrogen, vaginal estrogen blood clot, the guideline will come up. Or ACOG, vaginal estrogen, breast cancer, the guideline will come up. So the only group of people that I've seen anything around caution with vaginal estrogen are very rare, aggressive types of gynecologic cancers. So if that's not you, odds are you can use vaginal estrogen. And I hope that your primary care provider or gynecologist or whoever you're seeing is up to date on that data. So we can get this very effective, very affordable treatment.
Do you ever have patients that come to you and say they can't handle the inactive ingredients and you need to have it compounded?
Yeah, not too often. I have had some people that I switched to Intrarosa or DHEA because they're not reacting so well to the vaginal estrogen cream, maybe the preservatives in there. If someone already has a bunch of tiny little cracks and dry areas on the vulva, and then you're adding as preservatives, it can cause irritation. So sometimes if you get the tissue healed up with something compounded or the DHEA, then maybe you can go back to it later. But yes, I have had that from time to time.
Okay. Yeah, I've just heard of people having to have it compounded. So that was what I was curious about. And then beyond medication, are there lifestyles or supportive measures that we can do to help alleviate GSM?
Yeah, actually. So obviously staying well hydrated, taking a look at your other medications. A lot of medications are drying. Like you might not be thinking about it, but your antihistamine that you take for seasonal allergies can dry out your vagina as well. So taking a look at your medications. And then interestingly, yoga can be, I've seen pretty impressive studies on yoga for genitourinary syndrome as well, as far as like the arousal and lubrication piece. And also, you already mentioned pelvic PT. I can't sing their praises highly enough because, I'm constantly cross-referring. They're referring to me, I'm referring back to them because I don't do the muscle rehabilitation piece of this whole equation around urinary leakage, overactive bladder, things like that. And they obviously don't prescribe the hormones. So the two are like peanut butter and jelly, I like to say.
Yeah, for sure. I know I did a lunch and learn for nurses on menopause and perimenopause. And I told them, if you don't have a pelvic floor therapist in your Rolodex, you need one. Like you need to have a couple, but you should at least have one because it can be so beneficial. And the work that they do is specialized. It's not just Kegels while you're sitting at your desk.
Yeah. While I have the chance to bust this myth, a lot of people think no matter any kind of bladder leaking I'm having, it must mean my muscles are too weak and I need to do the Kegels. But certain types of leaking that can actually make things worse because sometimes it's related to too much muscle tension. So seeing a pelvic PT can help sort out, like the sorting hat.
Yes.
For Harry Potter. Which one am I? Or both.
It's funny. I did a really early on, I think before I even talked to you, I did an episode with, she and I did the health coaching program through the Women's Health Institute together. And so I had her come on talking about how pelvic floor health is more than just doing your Kegels. And she said that a lot of times it's not that you need to tighten, it's that you need to release. And I was like, oh, I'm sure I'm tightly wound and need to let go every now and then.
Yeah. If you are checking with your jaw right now and you need to relax it, chances are pelvic floor is the same.
Yeah. And so we talked all about that. So that's actually, maybe I'll tag that in the show notes too, because that was a good discussion around the incontinence that's like urge incontinence. That's what words are hard today.
Yeah. Generically speaking, stress incontinence, which is like coughing, jumping, sneezing, is when you leak. That usually does mean that you need to strengthen the pelvic floor, versus urge incontinence, where it's like you hold it, and then you touch the door to the bathroom, and that's when you leak. That is more often related to pelvic floor tension.
Yeah. Well, and I could tell you when I was having those issues, tension would definitely be something that I could complain about. Yeah, I was that way. I would make it hours and hours, and then I'd be driving home and I'm like, oh my gosh, like I can't even, like, knocking the kids over to get to the door. Like, get out of the way, kids. Mom has to go to the bathroom. That was clearly an issue for some pelvic floor PT, but luckily not so much anymore. And they're driving. Like, the oldest is driving, so that's a whole different story, which is a blessing, by the way. Yeah. Like, it was scary at first, but now it's so nice. Mm-hmm. The mental space that frees up is quite impressive, but that's a whole nother conversation for another day. And you're not there yet.
What was that?
You have little ones. You're not there yet.
Yeah. Almost 4.
Yeah. So it's not even close. But when you get there, it's pretty impressive. So if there's one takeaway that you'd like every midlife woman listening to this conversation take away about vaginal estrogen and GSM, we'll throw that in there, what would that be?
Something that came to mind while we're talking about pelvic PT is that I could potentially give you vaginal estrogen or vaginal DHEA, perfectly heal up the tissues. There's no issue with the health of your vulva or vagina or anything like that. And you have the lubrication. And yet your body still remembers that for the last few years, it was painful every time that you tried to have penetrative intercourse, and your body can kind of seize up in response to that. So working with pelvic PT or maybe even a sex therapist around breaking that cycle can be a really important part of the equation, so that you can get back to feeling more comfortable and relaxed and letting the muscles loosen up. Yeah.
Because pleasure is an amazing thing. We all need to be able to have good, enjoyable sex in our lives. And so I think that's an important piece too, because it's not just fixing the anatomy. Mm-hmm. Thank you for that. It's funny. I was like, how are we going to have a conversation about vaginal estrogen specifically and have it be more than 12 minutes? And we're at 33 minutes and 10 seconds about GSM and vulvas and estrogen. And like, are there any other blacklisted words we can throw in for the transcript? Is there anything else that I'm forgetting that I feel like that I didn't even touch base on that you think is important for women to know?
I don't know. Tell your grandma. Everybody can and should be using this. And I don't personally have this, but I've even heard of patients that don't have the dexterity to use the vaginal estrogen and maybe see their provider every 3 months for the vaginal ring. So there are ways to get vaginal estrogen even when you're much older, and it's very safe. And if it can keep you out of the emergency room or the ICU for sepsis that started in your bladder, that's very important work. So.
Yeah, and nursing home workers. Yeah, I mean, people that work in nursing homes and with senior facilities should really know, especially when you're seeing recurrent UTIs happening. I mean, I don't want to just say it should be in the water in a nursing home, but you almost should. It should just be a standard on the med sheet at this point for females or for people with female parts that would need it. I think that, I remember visiting the nursing home with my grandmother being there and that being an issue for a couple of the women there. And there's no reason that should be an emergency room visit.
Yeah. No, it's very, very common in that setting.
And the dexterity, I didn't even think about that, because you are expecting a woman to be able to vaginally insert something on a consistent basis. So the ring is a really great option.
Mm-hmm. Yeah, I love it. I mean, once again, no generic for it, but it's such a great option. Yeah.
Yeah. I mean, you insert it and forget it for a quarter of a year. So that's pretty good.
Yeah.
Yeah. Okay. All right. Well, thank you so much for coming on and talking with me about all of this. I feel like we've pretty much covered. I mean, if you walk away from this conversation and still have questions about vaginal estrogen, I'll have your information that they can reach out and find you on social media. And I'm going to add in the menopause rating scale. I'll put the GSM guidelines that were just released on there. It's pretty meaty. I mean, if you're not a clinician, it's a lot, but it might just be something that's nice to hand to your doctor and be like, hey, have you read this lately? Because, even in the conclusion, it tells me I should have vaginal estrogen. So that's a good thing to have in your purse when you have a doctor who doesn't quite keep up with all the reading.
Yeah, with the highlighter.
and little annotated Post-its on the sides. Yes, absolutely. So thanks for coming back on. It was nice to see you. We do need to schedule a time to visit socially since we live so close.
That's right. I'm looking forward to it.
Thank you for listening to this episode of Women Mastering Midlife. If something you heard today resonated, I'd be so grateful if you'd share it with a friend who might need a little extra support on her midlife journey. Remember, small changes can make a big difference, and you don't have to navigate this transition alone. We will be back next week with more expert guidance and compassionate conversations to help empower you to master midlife on your terms. Until then, you can find us on Instagram at Women Mastering Midlife, or come connect with me directly at Miss Victoria Bird. And you're looking for deeper connection and support, be sure to join us in the Women Mastering Midlife community. We'd love to continue the conversation with you there. If you've enjoyed this episode, please rate and review this podcast. It helps us reach more amazing women mastering midlife just like you. You'll find all the links from today's episode and ways to connect in the show notes below. See you next time.